Okay, Dr. Hauser, it's all you. Please get
Yes.
started.
There's some recommendations for standards for epidemiologic studies for epilepsy, and they're also, I think, important for any clinical studies, because I don't think you can do any studies at all unless you start off and have very clear definitions, and that's very clear definitions of everything you're including in your studies. So, we have conceptual definitions of a seizure: a transient occurrence of signs and/or symptoms due to abnormal, excessive, or synchronous neuronal activity of the brain. I don't think there would be a huge amount of arguing about that. That came from Fisher, but I think that there are several other references, including one of my own some 40 years ago. But we need to have an operational definition, because you can't study anything clinical unless you can define what you are going to study. And so we will call a seizure the signs or symptoms including sudden transitory abnormal phenomena, such as alteration of consciousness or involuntary motor, sensory, autonomic, or psychic events perceived by the patient or an observer. So you need not only to have a conception, but you need to have something that you're going to be looking for. And I think that this probably covers pretty well what you would be looking for in terms of a seizure. We want to study epilepsy. And from my standpoint, epilepsy is a disorder characterized by an enduring predisposition to generate epileptic seizures, and by the neurobiologic, cognitive, psychological, and social consequences of this condition. This definition requires the occurrence of at least one seizure, and that again comes from the position paper of Fisher from 2005. Operationally, epilepsy is considered a condition in which seizures tend to recur, and so we define it as a condition of 2 or more unprovoked seizures occurring at least 24 hours apart. And there are various reasons for that particular definition, and I think it's been relatively well documented in studies to show that recurrence risk for seizures, for unprovoked seizures, is about the same if you have multiple seizures, or for that matter, status epilepticus as a single event, or in a 24-hour period. More recently, there have been some attempts at modifying this using some mathematical formulas to include additional people as having epilepsy, despite the fact that they've only had a single unprovoked seizure. The suggestion was that an individual with a risk equivalent to that of an individual with 2 unprovoked seizures should be considered to have epilepsy. This was in a paper which was published in 2015. Again, it was a commission report headed by Fisher. Unfortunately, there, to my knowledge, are no clear indicators of events that reached that level of risk. Now, in that report, they recommended using the lower confidence intervals of the risk, which is about 60%. But even so, there are very few situations identified thus far to push people over that 60% risk level. I personally look forward to seeing studies which might help identify such things. Now this is an old study of mine, and it just shows what happens when someone has a single seizure. And you can see this, and I don't know if there's any way we can point, but you can see the lower curve here shows recurrence risks, and we go out to 100 months, and in this particular situation, in a heterogeneous group with a first seizure, about 37% had recurrence. Whereas after 2 seizures or after a 3rd seizure, you can see that between 75 and close to 80% of people have further seizures. I think that that's a rather clear distinction, and I think in my mind continues to suggest a substantial difference between those with 1 seizure versus those with multiple seizures, and suggests that the tendency for recurrence may be somewhat unique. For this reason, I think that from an epidemiologic standpoint, I think it's appropriate to use the 2 seizure definition. Now, what is epidemiology? It's a study of patterns of disease in populations. It's not a study of individuals, although I think that definitions are just as important in an individual patient as they are in our attempts to study conditions in populations. So the epidemiologist wants to know who gets the disease, why do they get the disease, and what happens to people with this disease. Epidemiologists are really interested in prevention. That's the whole purpose of epidemiologic studies. And I think with some recent things that at the Academy meeting, for example, with some discussions, I think there's some confusion about epidemiology and international care types of things. The epidemiologist is interested in distribution of diseases in populations, and so he frequently will do studies in a diverse set of conditions, countries, geographic regions, and so on. And in doing these, very frequently gets involved in attempts at interventions. But epidemiology is not necessarily directly associated with the global health. I think that those are different things. And the global health initiatives of the AAN and the epidemiologic initiatives are different. At any rate, epidemiologists want to prevent the disease. If we're really successful, we wouldn't have a disease to deal with it. And those efforts would be primary prevention. Once epilepsy has become manifest, the epidemiologist is interested in prevention of the progression or the occurrence of adverse factors associated with the disease. That's secondary prevention. So we would like to keep things from getting worse. Then there's a concept of tertiary prevention, which is attempts at providing interventions to allow people with the condition, such as epilepsy, to cope with their condition, and I suspect that would also include families, relatives, and so on, to cope with the condition that of epilepsy. Now, I have to say that as far as I can tell, we have been totally unsuccessful in goal number 1, primary prevention. Although I think this shows some of the fallacies of looking at gross data. There's recently a paper that's been published suggesting that there has been no change in the incidence of epilepsy over some 50 or 60 years or something of that nature. So that if one takes that into account, we're not doing much. On the other hand, I think there are very convincing studies, and there are now probably 6 or 7 different communities where epidemiologic studies have been done over time in children, and it's clear that the incidence of epilepsy, that is, new cases of epilepsy, have fallen by probably 40 to 50% over the last 30 to 50 years. Now, the problem is, it's not clear why this drop has occurred. So, in children, at least in industrialized countries like Italy, the United States, Sweden, Finland, Great Britain, where these studies have been done, there does seem to be an effective reduction in the frequency of new onset epilepsy, but no obvious explanation for why. Most of these changes preceded any obvious great changes in pre and perinatal care. But if you look at the overall frequency of epilepsy, this decrease in children has been counterbalanced by an increase in the number of new cases of epilepsy in the elderly. I think this can be explained, even though we know that the incidence of stroke is decreasing. Survivorship from stroke is increasing, and roughly 15 to 20% of people that have a stroke over a long-term basis can be expected to develop epilepsy. And so we have many more epilepsy cases in the elderly. But we're totally unsuccessful in terms of identifying any reason for the decrease. In terms of secondary prevention, one measure one might look at is mortality. And over the same period of time, again, there seems in population-based studies to be little evidence of change in mortality. And some people have suggested maybe some of our new medications are more effective. At least these types of studies seem to suggest that this is not the case. These are almost asides, but prevention is important, but we need to understand the condition before we can prevent something. The epidemiologist uses some measures that people frequently get confused, and I'm going to talk about that. I don't plan on talking about prevalence and incidence numbers. I want to talk about some concepts, though. Prevalence is the number of people with a disease, and in this situation, epilepsy, in the population at a specific point in time or period of time that have epilepsy. It's usually measured in terms of number of cases per 1,000 population. It's more useful if it's broken down into number of cases within age groups and by gender. So a global prevalence number is of little use. More important is to have prevalence within age and gender and by other important demographic breakdowns for comparisons and adjustments. Prevalence, people love to do prevalence studies. Everybody wants to know what the prevalence is in my community. I think the prevalence studies are a predecessor to doing incidence studies, which are much more important. But the basic use of prevalence studies is determination of disease burden, and through that, determining things like the amount of medical resources needed, the number of clinics needed, the number of rehabilitation programs, the number of surgical programs that might be necessary should one want to implement this on a population level. Prevalence can give clues to causation, but it's quite complex because prevalence is a mix of survivorship and for epilepsy, remission or lack thereof. So if one looks at the usual prevalence numbers, on average one sees a prevalence of between 5 and 6 or 7 per thousand. But if one uses a similar age distribution, one would expect probably 2% of the population to have had epilepsy at some time. And while some will die, it suggests that a substantial proportion, at least half, no longer have epilepsy by most definitions and don't count as prevalence cases. Now, I do have a slide here just showing age and gender-specific epilepsy prevalence from a study which we did in Iceland. You can see, as one would expect, prevalence increases from childhood into adolescence. It is relatively constant across all age groups until you get into those over age 60, and then it tends to increase. When we talk about prevalence, we try to talk about active prevalence, and by that it means people that are affected at the present time with the condition. There are various definitions that have been used for active prevalence, but generally for an active prevalence case is somebody who's had seizures in some specified period of time in the past, or is using anti-seizure medication for some particular time in the past. And for most of the studies that I've done, that period of time has been 5 years. I think somebody that hasn't had a seizure in 5 years and is not taking anti-seizure medications for that period of time is not likely to be a major burden for epilepsy in society. There are also lifetime prevalence measurements, and that implies somebody who has a seizure at any time in their life. There are a number of studies that report this lifetime prevalence. I'm not sure how to interpret them. And the reason I'm not sure how to interpret them is because it only includes people who remember that they have epilepsy. So if one considers what the incidence of number of cases should be, the lifetime prevalence is usually about half of that, of what one might expect that from a cumulative incidence measurement. Not only does we have to worry about definitions, because not only does the definition of epilepsy vary, some people don't just use recurrent unprovoked seizures, but so does the definition of prevalence. This is from a study that was presented by Borneo in, I guess about 15 years ago, but I think it shows the impact on definitions on the prevalence of epilepsy. And this shows the last seizure occurrence and prevalence. So if you say an active case is anyone with seizures in the past year or 2 years, the prevalence in this particular study in South America was 8 per thousand. If you use the 5-year definition, the prevalence of active epilepsy would be 13 per thousand. So you can almost double the prevalence by changing these numbers. So it's important to look at these numbers, see how they're defined, and because you can just this little twist to 2 or 3 or 4 years can substantially change estimates. These are some estimates from some recent studies in children that you can see from developed countries. In children through 14 or 19, between 3.5 and 7 per thousand. For developing countries using the same definitions of seizures or medications the preceding 5 years, we do see a somewhat higher prevalence, suggesting a higher frequency, and that then gives us some clues that there may be differences, and one may want to go to see why there are differences in the countries, and it may give you clues to causes. But this just shows the cumulative incidence, 1% by age 20, 2% by age 45, compared to their prevalence of 0.5% overall. And you can see, depending on how you define seizures or epilepsy, that if you consider recurrent unprovoked seizures, which I will define as epilepsy, by the age of 80, about 4% of everybody will have had a diagnosis of epilepsy. From this study, about 12% by age 80 will have had a seizure of some type, including febrile seizures or other acute symptomatic seizures. So again, you can change these numbers just by changing who you're including. On the other hand, I'm not sure you want to compare a group of people with unprovoked seizures and a group of people with febrile seizures, because their age of occurrence is quite different, as is the cause and the overall prognosis. And this is just a graph showing the differences between lifetime prevalence and of active prevalence in some studies that we've done in Rochester, Minnesota. You can see it's correspondingly an increase in about 10% within each age group. Sometimes when people report active prevalence, one sees bizarre results. So in this study from Egypt that was published last year, one sees a lifetime prevalence of 6% in children between 0 and 4, 4% in children 5 to 9, and 3% in children 10 to 14. But since this is lifetime prevalence, the prevalence should not decrease, it should increase, because there are more children developing epilepsy between 5 and 9, and the only way one could explain this strange change would be either mortality, meaning that 4% of the population, the total childhood population, is dying of epilepsy. That could be one explanation. You could have outmigration from where these studies are done. You can have many of the epilepsy cases going into special homes or something, which seems unlikely. You could have birth cohort effects, so that there was some particular major risk factor associated with the youngest age group, which increased the frequency of epilepsy. I think in all likelihood, though, it's more likely some problem with the sampling frame. But you see strange things, and you need to look at the studies in more detail. Incidence is of much more interest for epidemiologic studies. Incidence is the number of people with a new diagnosis or new onset of a disease in the population, generally determined over a specific period of time. For epilepsy, it's usually number of cases per 100,000 population per year. Again, it's more useful if broken into number of cases within age groups and by gender or other demographic variables felt to be important. Incidence is important is because it gives us clues to causation. It's close to the time of event. The cases are not as influenced by mortality. So it can give information regarding mortality and remission. It could also give clues regarding various comorbidities. So one to study things like the association of depression and epilepsy, which is clearly bidirectional, really requires incidence studies of epilepsy to determine comorbid risks. Now, these are some relatively recent studies of incidence in all age groups. And I think this is relatively characteristic. The incidence of epilepsy is quite high in the very young and quite high in the elderly. And in the most recent studies, in most, the incidence of epilepsy is actually higher in those in the older age groups than it is in the early years of life. Now, what are necessary for reporting incidence and prevalence? You need to report age and gender separately, and this then allows you to do an age adjustment so you can actually make comparisons across studies. The age adjustment is crucial because if you look at most incidence studies, for example, from developing countries, one has the impression that there's a very high incidence. But if you do an age adjustment, the incidence is probably not much higher. It's only because of a different structure of the population. And in part, but not totally, but in part, the apparent discrepancy is related to differences in the age structure of the underlying population. So global incidence or global prevalence numbers are of use for politics, but probably not of much use for science. And there are some guidelines, other guidelines. I don't want to bore you with more guidelines, but there's some guidelines, strong guidelines, and I'll see if I can find the reference for those on reporting descriptive studies, which emphasizes the need for direct or indirect age adjustment. Now, we're also interested in mortality, the number of people with the disease who die. And this is an important area, I think, clinically, obviously, but also for epidemiologists. But there are a number of potential measures, and they can be confusing. We can have deaths attributable to epilepsy per 1,000 or 100,000 population. This number actually is about 2 or 3 per 100,000 per year. One of the problems, of course, is that these are determined based upon death certificate recordings, and only about 10% of people with epilepsy have epilepsy on our death certificate, and an equal number of people that never had epilepsy have epilepsy on a death certificate. So death certificates are a pretty poor way of recording, getting any information on any disease, including and particularly epilepsy. You may want to study deaths among cohorts of people with epilepsy. You may want to study the case fatality rate. So you have cases and you want to determine the frequency of deaths among that cohort. And that may be a bit more meaningful and may at some level allow comparisons to be made. You can also look at cause-specific mortality in this manner. In many of the studies of mortality, you see SMR reported, a standardized mortality ratio. And this is a comparison of the ratio of deaths expected preferably in the non-epilepsy population compared to that with the people with epilepsy. Practically, this is more likely to be comparisons to death among an epilepsy population compared to deaths in the overall population, including people with epilepsy, since they would be included in only a small proportion of cases. Now let's see if I put this. One of the problems with standardized mortality ratios is you can't make comparison across studies. Since these are standardized rates, you cannot make comparisons across studies unless the base populations are similar by age and gender. They do, however, give you within group comparisons. And in most epidemiologic studies, for all people with epilepsy, the SMR is about 3. That is, there's about a 3-fold increase risk for epilepsy people to die compared to the general population. That, of course, will vary by age, by gender. So these, again, become important. It also varies by type and cause of epilepsy. So if, for example, one has epilepsy of unknown cause, the risk is about 1.5, but drops down to baseline population risk between 5 and 10 years after diagnosis. In people with only a single seizure, there's no increase in standardized mortality ratio. On the other hand, people with symptomatic epilepsy, the risk is considerably higher, and that risk is determined by the underlying cause, like stroke or brain trauma and so on. But these are the methodologic problems. They're not comparable across or even within studies unless the distributions of the populations are similar and that there are similar age and gender death rates. Why do we need standards? We really would like to compare studies. We'd like to compare prevalence studies. We'd like to compare results from incidence studies. But we can't do this unless we're talking about the same thing. Now, in the paper that I gave you the list, and this is something that Susan asked me to talk about, there is discussion of a categorization of probability of seizure risk, or seizure diagnosis validity. So, quality of evidence, either clear evidence of recurrent epileptic seizures or documentation of a diagnosis by a competent person are criteria which I think most people would accept. And for a definite case, they talk about primary documentation that meets criteria A or B, probable indicating likelihood that these are met, and suspect where there may be something there. I'm not aware of any epidemiologic studies that have used a breakdown of this nature. We have used a breakdown of this nature operationally within studies, for example, in incidence studies, which you did in Iceland. But we've always only reported definite cases. That is, cases that we felt was clear medical diagnostic information that people were had epilepsy. And I must say that in Iceland, at least, the suspect cases in the elderly were substantial. We had at least twice as many individuals that fell into a suspect category over the age of 70 as we had with definitive diagnosis. Epilepsy may be frequently highly underdiagnosed in the elderly, which gets us maybe to a primary or secondary prevention issue. Minimum data set to be collected for epidemiologic studies. Age of onset is important. The clinical manifestations by seizure type, syndrome, if possible, but it's seldom possible in epidemiologic studies. First, if one's doing an incidence study, it's frequently difficult to identify the syndrome with just a few seizures. And second, in most epidemiologic studies, people don't have the expertise or the diagnostic facilities to allow appropriate diagnoses by syndrome. I think one wants to have a potential etiology, and any comparisons must allow for age adjustment, so those comparisons can be made directly. Now, this is taken again from that paper, and it's a modified seizure type classification for epidemiologic studies. And I'm just going to make a few comments. I think the seizure classification is one which is likely to be used if one is trying to get information from individuals that don't have full medical knowledge. And you can see that we broadly classify cases in the generalized, focal, and undetermined. And I think it's important to remember, there are many people who are going to be undetermined, particularly in epidemiologic studies. So you need to have this category. There are a number of studies, particularly studies from Africa, that talk about convulsive epilepsy. I can see practical reasons why this is done. It's difficult to describe, I think, an absence seizure. In studies in the Navajo, for example, there is no term for it. I'm sure that's the same case in some places in African countries. And one perceives that somebody will recognize a generalized seizure, so there may be some level of comparability across studies. But my problem with this term is that it's eliminating large classes of seizures, large classes of epilepsy, but you're not sure what's eliminating. For example, is a myoclonic seizure a convulsive epilepsy? Is a focal motor seizure a convulsive epilepsy? Are the lip twitches in somebody with benign Rolandic epilepsy, in a child with benign Rolandic, is that a convulsive epilepsy? The problem is, and this again gets back to definitions, what is convulsive epilepsy? If I say you had a convulsive seizure, I think everybody has a picture of what that is. But if I'm doing a study on convulsive epilepsy, I'm not sure I know what you mean unless you are very specific about what you mean. And very few, if any of these studies are very specific. So I personally take fault with these studies unless they provide specific definitions of what they mean. The other thing that becomes important are an etiologic classification. And this taken from the paper that I gave you the reference from. I have some things highlighted in red here because I don't necessarily agree with the total classification, but it's very nice to be able to make comparisons over time. So in studies that were done in the past 2 or 3 decades, one divided cases into symptomatic or idiopathic or cryptogenic epilepsy. And in the latest classification, which is probably going to be changed yet again by our current, by the emails I'm getting with requests to review classification systems, genetic or presumed genetic is at some level probably equivalent to idiopathic, so one can make some comparisons. Structural metabolic probably would have been inclusive of symptomatic, and the current unknown probably would be equivalent to cryptogenic. And again, I would like to stress that unknown or undetermined is an important category, particularly for epidemiologic studies, but even for clinical studies. You shouldn't be afraid to say that I don't know. I don't have enough information. In many areas, you're never going to get enough information. So one can make a distinction, and I think the distinction here is unknown is despite adequate evaluation, undetermined means that you don't have an adequate evaluation. One of my problems with genetic and presumed genetic is that seldom has presumed genetic been defined. Presumed genetic is, I think, probably encompasses many of the seizure types of syndromes, such as juvenile myoclonic epilepsy or absence epilepsy, which seem to occur more frequently in families, but which, in my mind, are not yet clearly established as, quote, genetic. I think that the genetic component here may actually be more related to an EEG phenomena, which is more likely to be genetic than the epilepsy itself. But that's another question. But again, I think that if one is going to talk about presumed genetic, one needs to establish what one is presuming to be genetic. And that also seems to cause some confusion, at least in my mind, about classifications under the structural and metabolic, because we have neurocutaneous syndromes, many of which are genetic, but I guess since there are clear structural abnormalities associated with tuberous sclerosis, for example, it probably is classified under symptomatic as opposed to genetic. And I think one may say the same thing about inborn errors in metabolism, although I can't help thinking of Dravet syndrome, for example, being not very different from many of the other inborn errors in metabolism. We have, I guess it depends on how far you're going to go in terms of where that error starts, whether so nose counting can be difficult. I think there's a perception that doing incidence and prevalence studies is simple, and it's probably not important. I think it's key because it's the first step in terms of understanding conditions. It's not until you determine a total population of people with epilepsy that you start to realize that there are a substantial proportion of people that stop having seizures, that you start to realize the frequency of mortality, that you really appreciate not only the importance of certain comorbidities like depression or migraine, but realize that they're on a continuum, and you need to be able to get directionality, and you can get that only from incidence studies of the conditions. There's clearly a need for standardization and adjustments, and I think these issues are all equally important for clinical studies as well. So I'm going to finish with just the concept that we need to define things, and changing definitions makes dramatic changes in outcome. Just as an aside, I've just reviewed another paper, but simple change in definition and ICD coding is associated with a six-fold increase in apparent epilepsy hospitalizations after 2006. Definitions. You've got to have consistent definitions. I'm going to stop there, but I'd like to take any questions, and I'm not going to talk about the more exciting things like prognosis and remission and mortality and comorbidity, which is the things you start doing after you've done these basic descriptive studies.
Thank you, Dr. Hauser. Fellows, do you have any questions? Are there any questions you had for the fellows, or anything else anyone would like to bring up?
I did not give what I would consider to be a classical epidemiologic lecture. I tried to do something more on methodology, and I hope that was useful. But if you want a more standard epidemiology lecture with numbers and stuff, I'll be happy to do that too at some time.
Thank you. No, I think these fellows are working on mock research proposals, as I think I explained to you. So a review of the methodology, I imagine, is very useful for them.
Yeah, but no, thank you. It was very good. I liked all the examples that you gave. It was a very interesting talk. Thank you.
Thanks, Christina. All right. And I think that ends it for today. So thanks again, Dr. Hauser. We really appreciate your participation today.